Hello everyone. Today we'll be discussing a class of drugs called phosphodiesterase 5 inhibitors, commonly referred to as PDE5 inhibitors. PDE5 inhibitors are commonly used to treat erectile dysfunction, which is the inability to achieve an erection or simply difficulty in maintaining one. Erectile dysfunction, or ED, affects hundreds of millions of men worldwide. A 2013 survey of 1,674 Australian men reported that only 39% did not experience ED, with the remainder either experiencing it occasionally or constantly. It is important to note that the prevalence of ED also increases with age, with 70% of men aged 70 or above being affected. Not only, but ED can be associated or brought upon by a series of other factors, such as hypertension or smoking. Thus, it is an important topic in the current medical industry and in the pharmaceutical industry, in hopes of finding and developing the appropriate drugs to reduce the prevalence of ED worldwide. Erectile dysfunction was originally classified into two types, organic or psychogenic. However, with today's understanding behind the mechanisms of erections, most cases will occur from a combination of biologic, psychogenic, and interpersonal factors. These cases are more commonly seen. However, psychological cases are seen more often in younger men, and biological cases are seen more in older men. Oral PDE5 inhibitors have been proved to be an effective treatment for erectile dysfunction, which has fostered further research into the mechanisms of PDE5 inhibitors. In order to understand how PDE5 inhibitors work, let's have a quick look on the anatomy of the penis. The penis consists of three cylindrical chambers, the paired corpora cavernosa and the corpus spongiosum, which surrounds the urethra. The internal pudendal artery provides the main blood supply to the penis, which then later branches off into sections such as that supplying the corpora cavernosa. It is important to note that the penis is not only controlled by somatic nerves, but via the autonomic nervous system. Not only does it receive sympathetic stimulation to stimulate penile smooth muscle contraction and in turn lead to the penis being flaccid, but also has parasympathetic innervations, which are what are responsible for vascular smooth muscle relaxation and erection of the penis. An erection occurs following sexual arousal, however it is not entirely under conscious control. Stimulation from the brain travels to the sacral plexus, where the acetylcholine released acts upon the endothelium cells within the erectile tissue, causing a rapid release of nitric oxide NO. The NO stimulates the synthesis of cyclic guanosine monophosphate cGMP from guanosine triphosphate or GTP, which then downregulates intracellular calcium levels, resulting in smooth muscle relaxation, increased blood flow to the penis, and filling of the cavities in the corpora cavernosa, producing an erection. PDE5 is an enzyme that breaks down cGMP. Thus, PDE5 inhibitors cause an accumulation of cGMP which produces and maintains the erection. There are multiple isoforms of PDE5 inhibitors, all which have chemical structures to be able to serve as competitive inhibitors of PDE5. Sildenafil and vardenafil, for example, have similar molecular structures, whilst sildenafil differs. An analysis of studies found that 2.5% of men reported having adverse symptoms after taking sildenafil. Also, repeated exposure in healthy men increased sensitivity to nitroglycerin and exogenous NO donor approximately by 4-fold. PDE5 inhibitors used in conjunction with NO donors can lead to significant arterial hypertension. Both PDE5 and NO donors cause vasodilation of blood vessels, thus they can cause a dangerously fast reduction in blood pressure. From this pie chart, you can see the deaths associated with taking nitrous and sildenafil. So, do not take both at the same time. PDE5 inhibitors can also lead to priapism in some, which is a prolonged erection.
Mr. Burgundy, you have a massive erection.
Really? Yes, I do.
And can also lead to relaxation in unwanted smooth muscles, such as the sphincter between the stomach and the esophagus, that can lead to gastric acid traveling up, causing symptoms of heartburn or nausea. Lastly, let's talk about PDE5 inhibitors and their drug interactions. They exhibit higher plasma concentrations when taken with cytochrome P3A inhibitors, which influences their side effect profile, influencing the severity at which they interact with other drugs and thus require an adjustment in dosage. Fortunately, PDE5 inhibitors are safe when used with most antihypertensive agents. However, co-administration with nitrates or antihypertensive drugs such as alpha blockers, angiotensin-converting enzyme inhibitors, calcium antagonists, or diuretics are a big no-no, as they can cause severe vasodilation, life-threatening hypertension, and syncope. Adversely, this combination can be used as therapy if the vasodilation remains relatively selective for the pulmonary vasculature. Potent CYP50 and 3A4 inhibitors such as erythromycin, ketoconazole, and HIV protease inhibitors also increase PDE5 inhibitor plasma concentrations, requiring dose adjustments. Lastly, administering sildenafil to patients with PHT already taking ipraprostenol, iloprost, NO, or bosentan can improve an area of hemodynamic, clinical status, and exercise capacity parameters with little to no effect on systemic blood pressure. Overall, PDE5 inhibitors are used to treat erectile dysfunction, which is highly prevalent worldwide. It does so by inhibiting the enzyme that breaks down cGMP, thus allowing for an increase in the relaxation effect of NO to produce an erection. PDE5 inhibitors are highly effective with a low-dose profile. However, should not be used in conjunction with nitrates or antihypertensive drugs.